The views expressed on the following program are designed to amplify those of the speaker and not necessarily those of KAAM, DJRD Broadcasting, or its sponsors.
It is time to Ask the Pros, the only live local interactive radio program that addresses home, health, and wealth matters Monday through Friday. A program hosted by arguably the most knowledgeable and reputable authorities in their respective industries, affording you the rare opportunity to ask them any questions related to their field of expertise for free. Just pick up the phone and call KAAM right now to Ask the Pro. Now, here's Dr. Birnbaum.
Good afternoon, everybody. You are listening to Cancer Update, a short walk through a long journey. Hope everybody's doing okay out there in that very, very hot afternoon. Dr. Birnbaum hasn't made it to the studio yet. Want to remind everybody, if you have questions for Dr. Birnbaum or myself, you can call 469-453-5500. That number again is 469-453-5500. Had an interesting week out there in Cancer Land. Been a real busy week. We're doing a lot of outreach and a lot going on. Want to talk to you about the Cancer Genome Atlas. And that is something that we have done, scientists have done, as far as doing looking at the genetic makeup of cancers and gene therapy. It's something very new and very Star Wars-ish, but it is really having an effect on cancer, on how we treat it, on how we diagnose cancer. We now can look at cancers, we can look at tumors, and we can pathologists can look at it under the microscope, and they can test it. They can take chemotherapies, and they can put drops of the chemotherapy onto the actual pathology, the actual tumor, and they can see which chemotherapies work best for which cancers. Previously, we were not able to do that. We would have to go by what most people were getting. And as everybody knows, cancer doesn't follow the rules. Everybody's cancers are different. Even breast cancer, for example, there are lots of different types of breast cancer, and every individual reacts differently. We can test now. We can see what is your rate. How much is chemotherapy going to improve your survival? Is that going to make it 5% or 1%? Is it worth it? What type of chemotherapy are we going to use on you? We now can see, is breast cancer hormone receptor negative or hormone receptor positive? We can look and just see, how is that tumor fed? And that's all part of the Cancer Genome Atlas. If you get a chance, look that up. I want to tell you that tissues that they're looking at for study is brain cancer, breast cancer, gastrointestinal cancer or stomach cancer, gynecologic cancer or female cancer, head and neck cancer, hematologic cancer, that's like leukemias, blood cancers, skin cancer, thoracic cancer, which is throat, and urologic cancer. So that is something that you're going to be seeing more and more of. And this all relates on something that we did when we looked at the genes involved in the human body. It's very interesting work. It's not something that I think everybody understands, but it is affecting tremendously how we treat cancers, how cancers are diagnosed, what's your particular type of cancer. So it's an exciting time, certainly for me, to be involved in cancer navigation, because I'm able to share with people the good news of cancer, that we are treating cancer better than ever, that people are living longer with cancer, and that they're able to live their lives. So we really have a long way to go. There's a lot of cancers out there that don't get near the funding that they should, and I hope that we can change that. I hope groups like Stand Up to Cancer, sometimes it takes somebody famous getting a cancer before we do money for research. I hate that. Please remember that screening is still the best, most effective way to prevent cancer. My mother always said, don't be penny wise and pound foolish, and I think that is true. So we want everybody to get their mammograms. We want everybody to get their PSAs. We want everybody to do what they need to do. If you are a smoker, please stop. I had a friend this week who called me, and she was scared to death because her doctor scared her. And she mentioned to me that she had told her doctor she'd had an upper respiratory infection and went to her doctor. And the truth was she had never told her doctor that she was a smoker. And so her doctor was making her diagnosis based on the fact that she had said she was a non-smoker. And she scared the living fire out of her. And I spoke with her, and she said, I think I'm ready to quit. I've been scared into quitting. And she, has had this hidden fear. So if you are a smoker, find a place that will help you. Talk with your doctor. There are lots of great things out there that can help you in your journey to being a non-smoker. And please share with your doctor if you are. Physicians are not mind readers. They cannot tell you what you aren't telling. They cannot guess at what you are not telling them. So with that, we're going to start our program. Dr. B, welcome.
Hello, how are you?
I'm okay. Got a question for you, or an email from a listener. It says, hi, Dr. B and Tina. That really should be Tina and Dr. B. I'm going to have to let her know that because I go first. Anyways,
right.
Love your show. Can you tell me more about liver cancer? My mother was diagnosed with liver cancer, and now I'm just simply scared to death that I might get it too. Want to just, if we could, Dr. B, liver cancer. Do you treat a lot of liver cancers?
It's not one of my primary cancers.
But you have over the years.
Oh, yeah.
And you treat a lot. You treat a lot of people that have had metastatic disease from another site, and now they have metastatic disease in their livers.
Totally different way of treating them. When you're talking about liver cancer, you're talking about a hepatocellular carcinoma, which is a cancer that comes directly from the liver. Its primary site is the liver, as opposed to a metastatic cancer, meaning it went from the colon to the liver, from the lung to the liver, from the breast to the liver. And in those type of disease, the treatment's different, the approach is different, and the drugs are different. If you're going to treat a metastatic cancer from the colon to the liver, then you're going to use the drugs that are used for colon cancer, Folfox, Fulfuri, with or without obviously with Avastin because it's metastatic, and that's where you use Avastin. If you're talking about a primary liver cancer, which is seen more commonly in people that have had previous history of hepatitis C.
I was just going to ask you that.
That have had previous history of cirrhosis of the liver, obviously due to alcoholism or to other causes. But basically, the treatment for the liver tumor is, first of all, to do the appropriate studies. I like to do, you do an initial x-ray, they show an abnormality in the liver. I think one of the best studies to do is called an MRI of the abdomen with a dynamic imaging of the liver. That is a specialized MRI of the abdomen that concentrates specifically on all aspects of the liver and the biliary system. So having said that, now you've got it detailed. And if it is a fairly isolated tumor, then probably the best treatment ends up in surgery. Some people like to go first to embolize the tumor, meaning block off the blood supply, take it to a surgeon who is an expert in liver transplant or liver resection, have them go in there and resect the liver, or even, if necessary, do a liver transplant. That usually occurs if there's more than one lobe of the liver. There's basically a right lobe, left lobe, and the rietal lobe, R-I-E-D-L-E or D-E-L lobe, and that's kind of like a middle lobe that hangs behind the liver. So in the right hands, the best thing is to make the patient NED, no evidence of disease. And some people will go with the embolization first and then the surgery. Some people go right to surgery. But you need to bring in the surgeon in this case. It is not really a place if you have the possibility of doing surgery to bring in a radiation oncologist.
If I understand correctly, the liver is really kind of filters our body of toxins.
The liver and the kidney are the two main filtering systems of the human body.
So if I'm abusing my body, because one
Which
of the
is
risks,
true.
yeah, I abuse I don't just abuse you on a daily basis. I abuse my body. Thank you very much for that level of confidence. But if the liver is really a filter for our bodies, and let's just say I drink a lot of alcohol, that is going through my liver, correct?
100%.
And if I'm using lots of Tylenol or,
There's abundance of drugs out there that are either metabolized about, I don't know the exact number, I want to say 60-40. 60% are metabolized through the liver, 40% through the kidneys. My number may be off a little bit.
Mm-hmm.
But yes, you see the Liver Aid commercial on TV, and the little comic says, everybody's always talking about the heart. It's the liver that is the most important. And they're probably right. The liver is probably the most number one metabolic organ in the body. Unfortunately, in a cirrhotic, meaning a person who has liver cirrhosis from alcohol abuse, you can almost damage 60 to 70% of the liver before you become symptomatic, and that's shameful because the alcoholic, they get their lab tests back, and the lab tests are perfectly fine, yet they're drinking 2 or 3 drinks a day. Pretty soon it's going to hit that brick wall, and that liver is going to start showing damage. And part of the damage is due to lack of vitamin, thiamine, folic acid. Part of the damage is lack of protein metabolism. They become hypoproteinemic or hypoalbuminemic. And unfortunately for the patient, they don't realize this until it's almost gone too far. And to reverse that, once you get an individual that's been drinking that much and that long, it's hard for them to stop. It's probably even harder than it is to stop cigarette smoking because it's part of their system.
And they've been doing it for so long. Let me go ahead and read, if you're okay with this, to what the risk factors are for liver cancer. Chronic viral hepatitis B or hepatitis C infection.
Mostly C.
Mostly C. Alcohol abuse, cirrhosis, which is the buildup of scar tissue in the liver. Exposure to toxins. And, when we say toxins anymore in today's society, we don't know what we're exposed to. We don't know what's in our plastic bottles or so on. So there are people, I don't want everybody to think that anybody who has liver cancer has been a chronic alcohol abuser or hepatitis C, because people who don't do that and have those risk factors still can get liver cancer, correct?
That's true, but I would say over 75 to 80% of all liver cancers are patients who have had previous exposure to hepatitis or to alcohol.
Now, if somebody is diagnosed with hepatitis C or hepatitis B, are they looked at closer and do lifestyle changes? Are there things that they can do that you as a physician would do, or their family physician or whoever would do to try and get them to take care of that certain condition?
Well, there's some treatments out there. Interferon's used in treatment of hepatitis C and in B. And there's just continual surveillance of the patient and making sure that everything is correct. And they got to watch the patient in their liver function studies.
Anabolic steroid usage. And, that is on the...
Well, let's look at Lyle Alzado, the great football player for the Denver Broncos.
Yes.
He was a heavy user of androgen steroids, anabolic steroids. And when he was diagnosed with a brain tumor, he also had tumors in his liver. Very common to see people who take anabolic steroids develop liver tumors. Sometimes they're not malignant. But they're space-occupying tumors. The majority of the time, they are tumors.
And there's a difference between anabolic steroids and the steroids that your doctor gives you for poison ivy or such.
Much bigger difference. They're not anabolic. That's like prednisone.
I see. Okay, so there is a big difference. Then we have a family history of both hepatitis and liver cancer, and certain metabolic disorders such as hemochromatosis.
Well, hemochromatosis is an iron storage disease.
Okay.
It can either be to repeated transfusions, which is a secondary hemochromatosis, or a primary hemochromatosis, which, like I said, is an iron storage disease. I will tell you personally, in doing an adequate and thorough history of patients, I have never found a patient who had a primary liver tumor, or hepatoma it's called, or hepatocellular carcinoma, that had a family history. I've never found that. I've never found patients that came up to me and said they had neither cirrhotic or alcohol history or hepatitis that have had a hepatoma or had family history of liver tumor. So saying that you got to check their family history, you do that anyway if you're thorough. But in my experience, I've never had a patient who had a hepatoma, and you and I know some of these patients who had a family history of this.
A question, this is just from my family history, because I say, drinking and smoking, that's my family business. How many of your patients just lie to you that no, doc, I don't drink, I don't smoke, and how do you go about finding out if they do? What if your gut instincts is telling you that something isn't right? Or do you have that problem ever?
Fortunately, you always have a family member with them at the first visit when you do a thorough history before you do the physical. And a lot of times you'll say, well, do you drink? And they'll say, no. And the wife or the husband or whoever it is, a family member will say, whoa, what about those 3 beers you have? It depends on how people qualify what drinking is. A lot of people think when you say, are you a drinker, they think you're really boozing it, hard alcohol. They don't realize that 6 beers a day is a lot of alcohol, or drinking a 6-pack, or drinking a case of beer on the weekend to watch football games. Oh, I'm not alcoholic. Well, did you go to the game to say, Dad, you had almost a case of beer this weekend watching football or baseball or whatever. Same thing in response to cigarette smoking. I smoke 1 cigarette a week. And if you sit there and talk to them, or the family members say, whoa, wait a second. But in general, no, when you've got most of the patients I see, you have to understand this, have already been diagnosed with cancer. So they're already scared that what out of them. So when they come to you, they're
pretty humbled by it.
Well, this is a very personal meeting. They're taking you that this is a private, confidential doctor-lawyer, a patient-lawyer, client-lawyer, doctor-patient relationship, and this is a confidential conversation. And you don't discuss this with other people unless they give you the okay. Otherwise, you'd be in HIPAA violation. And most of the time, and I it's not me. I don't think it's me, but they're pretty honest with you.
You're a pretty approachable person, so I wouldn't think that you'd have that problem. But what about drug use? I know you've seen people who had either used recreational drugs or do drugs. Do you find any problem with that, or are they pretty much? They say, "Well, doc, yeah, I have been."
They pretty much come full force with that. Now, they will tell you about hydrocodone or OxyContin, but when you start wanting to get in, have you ever done marijuana, or you ever done cocaine or heroin? That's a little bit different question. That can be rather a case of denial. When you're talking about things like alcohol, or especially cigarette smoking, they'll say, no, I stopped cigarette smoking. I got a kick out of one of these patients. I said, oh, really? How much did you smoke? Oh, I used to smoke about 2 packs a day. And when did you stop? A week ago.
Yeah, when I ask that, they always say to me, "Well, yesterday."
Yeah,
and which I'm glad for them, and I give them, lots of praise.
Yeah, most of the patients, once they get the diagnosis, they mentally and they stop their self-indulgence because of their fear. I guess a lot of them think that. And in a way, they're right. If they stop their cigarette smoking, maybe it'll stop the growing of the cancer. There are all different reasons for stopping cigarette smoking once they get the diagnosis. But you'll find there's a lot of patients, and I mean a lot of patients, that failed to get their own screening fail to look after themselves because they say, well, I quit drinking 10 years ago, or I quit smoking, 20 years ago. Doesn't matter. The damage is already there. And especially if you say, how many cigarettes did you smoke? I was a 2-pack per day cigarette smoker. And how many years did you smoke? 20. Well, you multiply 20 times 2. There are 40-year history of cigarettes smoking. They may be 35 years old, or they may be 50 years old, or 60 years old. And they smoked for 20 of their 60 years, 2 packs per day. So 40-year history out of 60 years. It's a lot of smoking.
I was asking Hilly today because I have a friend who's really trying to quit. And, I teach stop smoking classes and, really do a pretty good job if I can be so boastful. My last class had 100%. But I was asking Hilly because I knew that Hilly had given up smoking. And so I asked her if she had used any of the drugs that are out there that can help you, Wellbutrin, and I can't think of the name of the other one, but Chantix. And she said no, that she didn't. But the interesting thing for the listening audience, Hilly's a fairly young lady in her early 30s, I think, and she said she was really tied to her inhaler and had to use it a couple times a day, and she's not had to do that. So the body really does do amazing things when you give up the smoking, and can do a lot and can help you a lot. So I want to mention that. Let me just real quickly go over the liver cancer symptoms, and then I have a question for you, Dr. B. The symptoms are, if you have pain in your upper abdomen on the right side, it can also extend to your back and shoulder, swollen abdomen or bloating, weight loss. And I noticed weight loss seems to be the number one thing in cancer. I hear you ask it all the time. Have you had recent weight loss? Is that one of the main things that you notice when somebody does have cancer, not just liver cancer?
Well, their immune system dramatically changes.
Okay.
Their appetites dramatically change.
Yes,
they become hypoproteinemic. They become hypoalbuminemic. They develop bloating and ascites, or fluid in the abdomen. When you start getting liver failure, you get ascites, or fluid in the abdomen.
Loss of appetite, feeling of fullness, weakness or being very extremely tired, nausea, vomiting, yellow skin.
Well, the weakness and the fatigue, not only do you develop this hypoproteinemic and hypoalbuminemic, one of the first things we always learn when you're dealing with a liver cirrhosis is they have very, very poor absorption of B12 and thiamine and folic acid, and that causes severe fatigue. So one of the first things we ever do with cirrhotics is start giving them injections of thiamine, and also that will help prevent the DTs, delirious tremens, and you start giving them oral folic acid.
Okay. Nausea, vomiting, yellow skin and eyes, and dark urine from the jaundice, and then a fever. So if you are out there and you have, some of these symptoms, please get tested and have
if you have those symptoms, remember another thing though. We don't want to scare everybody.
No.
You have right upper quadrant pain and discomfort. You could also have gas. You could also have gastric reflux.
I never have gas.
You could also have gallbladder disease, because that's the same place that the gallbladder is located.
One of the things that you mentioned, the gallbladder, and gallbladder cancer is called cholangiocarcinoma.
Cholangiocarcinoma.
Why don't we just have our gallbladders removed?
Well, cholangiocarcinoma is cancer not only of the gallbladder, it's mostly cancer of the biliary tract, not just the gallbladder. Gallbladder in and of itself has its own cancer, because the gallbladder is used as a digestive portal in the human body. Is it absolutely necessary? Not really. It's like the appendix is not necessary. It's like the uterus after you're giving birth to children. You don't want any more children. I would personally recommend the uterus be taken out, because it's like the number 3 source of cancer in women. And if you're beyond the childbearing age, or you don't want to have children, or you have a long history of fibrocystic endometriosis, fibrocystic disease, and fibroids, I would get that uterus out of there, because it has such a high incidence of cancer in women. And the only purpose, the only function of a uterus is to carry a baby. Serves no other function. Now, you don't have to have a total hysterectomy with a BSO, a bilateral Salping oophorectomy, where you take out both ovaries. You can take out the uterus, you can take out part of the ovaries, but no, maybe I'm a little bit overly aggressive about it, but most women, I've recommended that in the past.
I've always wondered if you just take. You and I've had this conversation about me because I've come to you and said, what parts of me can I just have taken out that will still help me to, have a good quality of life?
What was the first thing I said?
I can't remember. I think you said that. Oh, okay. He said that they could take out my tongue. Now, Dr. Birnbaum, score 1 for Dr. B. That's pretty funny. Okay, let's get back to the business of cancer now that you've slammed me. I've been seeing a lot of literature this week, reading a lot of the reports and stuff. I got to tell you something. Got me fired up. Got me real fired up. I read a report. A study was put out by McKesson. For those of you that don't know, McKesson is the company that makes a lot of oncology drugs, and they are also owners of...
They don't make them. They sell them.
I'm sorry, they sell...
They're the distributor.
They're the distributor, excuse me. So they're the distributor of a lot of oncology drugs, and a very big company in a big way, right? Billion dollar company. And they also are the owners of the largest oncology practice in Texas or the United States, excuse me. But they did a study, and the study showed that there's a 24% cost increase for somebody who has treatment in a hospital setting versus somebody who has treatment in a community cancer center. Now, I know I am prejudiced because I believe that a community cancer center I know not everybody can be treated in a community setting. Some people have to be treated in the hospital, and I get that. But in this age when we're trying to save dollars and be efficient in the care that we deliver, 24% is a large amount of money. And it also showed that toward people with end-stage disease, if they were closer to the end stage part of their cancer journey, the increase was 50%. So I want to ask you how you feel about that. It infuriated me. It just flat infuriated me that we were just wasting that much money. That could be a huge savings. So I want to know how you feel about that. And good stuff coming out in the literature this month.
Well, we're going to go over some articles. I think we ought to dedicate a session every program to keeping the audience up on some of the latest literature. We're going to do some spots on them today. But let's talk about what you just brought up because it's a double-edged sword. The other article you recently read that I gave you a copy of is that there's been a closure of over 32% of community cancer centers in the United States, either due to corporate pressure, economics, or inability to meet the bottom line. So on one hand, you've got the cost ratio, the difference in cost between getting your therapy in a hospital versus getting your therapy in an office, because not all oncologists can afford to give their chemotherapy in the office because of the cost of the drugs. The margins are very slight. So unless you're in a big corporate situation where they have better margins and they can pool the buying of the drugs and they can get a bigger discount on the drugs.
Can I interrupt you on that?
Sure.
As a patient advocate and as a cancer navigator or a certified cancer navigator, I can tell you one thing that can take care of this right away. Why do they not give the same discounts across the board? I do not understand that.
Volume. You got a customer that can buy 10,000 vials of 5-FU as opposed to somebody that's going to buy 500 vials of 5-FU. They're going to give a bigger discount to the guy that can buy 10,000 vials.
It still doesn't make sense to me.
It's business. It's the bottom line is business. These people are in the business of making money. I don't fault them for that. Okay, I really don't fault them for that. But it's an understanding. It also turns around to where the reimbursement is. And that's where your problem is everything is based on most of the time what Medicare is. So a lot of times private insurance will pay 115% of Medicare. So you're getting 15% margins. It just depends on the cost of the drug. And every quarter we get a printout on what drugs to use as far as cost benefit ratio. And we have to go by that. Otherwise, you're going to sit here and lose money. And that's one reason why a lot of community cancer centers have to shut down. Or they can only use certain drugs. Maybe this month you use Paxil, and next month you use Taxotere. Or 1 month you use Adriamycin, and the next month you got to use Epirubicin. Now, they're both anthracyclines, Epirubicin and Adriamycin. But the studies have shown that sometimes Adriamycin may have a 7 to 8% better response rate than Epirubicin. You got 8% on 1,000 patients. What's 8% of 1,000 patients? Is
yeah,
that means you're going to give up 8 patients?
No way.
Okay. 80 patients?
Yeah, there's no way.
So you got to treat them. You got to treat them with the better drug. The question is, what is your reimbursement? If not, then you got to put them in the hospital. Hospitals always have bigger margins. It's the same thing. For example, here's an article on robotic-assisted prostatectomy, cost significance, as opposed to a general prostatic urology doctor doing the surgery on you. The traditional prostatectomy is $8,600. To do it by robotic-assisted surgery is 62% higher at $14,000. And the majority of the additional costs due to this is the purchasing and the upkeep of the robotic equipment that the patient is paying for.
So the question is,
results. Let's go back and talk about results.
Okay.
The results are about identical. The side effects are probably better with robotic. You probably don't get as much bleeding with robotic as you do with the general surgeon, the general urological surgeon doing it.
Do you get better sexual function?
I think it's almost the same. But if you talk to the urologist, he may tell you differently. Okay? I don't know how the urologist, how much of that $14,000 they get as opposed to how much the hospital gets with the robotic equipment that they own. Or if a consortium of urologists own all this equipment. I don't know what the situation is for that. But I'm just telling you, this is article is out of Oncology Times, Hematology Oncology, and this is the July issue. And it's just, they're talking about different issues here dealing with surgery, and they're talking about robotic surgery. Results have been pretty good, very comparable to basic urological surgery, but the cost is almost twice as much.
And insurance pays for that, I
Yep.
guess, if you go through the proper channels and you can prove why. But as we move into the more economics of what's coming, whether that be Obamacare or rationed care or whatever you want to talk about, I can't imagine that robotic surgery is going to be in the future. I don't know. I guess you just don't know. And statistics, we don't pay a lot of attention to statistics in what we do, because I was in the infusion center this morning and I think I saw or met 3 people who statistically aren't supposed to be sitting in the chair watching TV talking to me. So I guess you have to balance it, and yet you understand the economics of it, the business of it. See, it's hard for me to balance the business.
How do you make a decision? If somebody could tell me this, when you have a patient, and you know who I'm talking about, who has stage 4 breast cancer from the get-go, a dirty breast, bone mets, liver mets, and lung mets, and her surgeon tells her, I'm not going to go back in and do your surgery and take away a month of your life because you only got 6 months to live. And her oncologist says, why do the chemotherapy? You got stage 4 disease. You run, your chances of living a year are less than 20%. Who makes the decision? The patient or the doctor? When the patient says, hey, I haven't even been treated, I want to at least have a chance of being treated. I want to be as aggressive as I can. Who makes that decision Should the government make that decision? Because statistically, this patient should be dead. Or does her oncologist make that decision? Or should the patient have the right to make the decision? They have good insurance, this patient. Excellent insurance.
Well, from a patient navigator standpoint, a cancer navigator standpoint, I firmly, with every power of my being, believe that nobody should take somebody's hope away. I think it all depends. I think it depends on if the patient is a fighter. Not everybody is a fighter. Some people say...
You and I know, after so many years in practice, the conflicts that I have had because of where I trained at MD Anderson and being proactive and aggressive, that some people think we're just overly aggressive, that we don't know when to stop. We have been very fortunate, and I will be the first to say that. We have been very fortunate in that a lot of our patients have gone well beyond the statistical average. Is the cost-benefit analysis worth it? If the median survival is 6 months and they lived 18 or 20 or 30 months, and part of that time they were on therapy, but they were with their family, they traveled, they lived a pretty good quality of life, is that worth the cost? Who's to make that decision, the patient or the government?
The patient. The patient. 100% the patient. I don't think the government, I don't think anybody has the right to take a hope away or to tell you when you are going to die. I don't think that, quite frankly, I don't think you doctors are that good at telling people when somebody is going to die. I've always hated the fact that a well-meaning doctor goes into a room when someone has been diagnosed with cancer. I'll give you an example. I visited a young lady in the hospital, and when I went into her, she was diagnosed with colon cancer. And when I went into her hospital room, she was crying. The longer I talked, the more she cried. And her young daughter was there, and you know, somebody well-meaning had taken all of her hope away. And the pathology hadn't even come back yet. And she happens to be a patient of yours. It wasn't you who told her this. Somebody else well-meaning somebody had told her.
A non-oncologist.
Yes, had told her. And this morning you shared with me that so far all of the lymph nodes look...
This lady looks like she's going to have an early stage B colon cancer. Her chances of 5 to 10 year survival are over 85%. If she's an early stage 2, there are some literature out there that would give her 4 months of FOLFOX, and she still has an 85% chance of 5 to 10 years. I personally get very upset when non-oncologists express their opinion about cancer treatment and cancer results when they don't know what the hell they're talking about.
Well, the other thing about it is that they caused this lady really unnecessary harm. When I went in, 3 days she hadn't eaten because she'd had surgery, and they were trying to make sure.
Well, she had her NG tube down, and they wouldn't let her eat or even take rice chips.
Correct. She was feeling pretty blue.
Which is standard.
I get it, but she was feeling pretty blue because she hadn't eaten. I mean, when you're laying in a hospital bed, food sounds pretty good when you don't have anything else to do.
It's obvious looking at this lady, she had eaten quite a bit prior to surgery.
That's right. So that was very important to her.
So she enjoyed eating.
That's right. And I think just pull that rug out from under her. And this morning I got an email from her, and we talked back and forth. And the difference between her then and now is night and day. She has hope now.
Well, she has the facts.
Correct. That's the point I'm trying to prove. We're going to go ahead and take a break.
Please join us back here for Cancer Update, a short walk through a long journey. The phone number here is 972-445-0770. Come back to us, call in, ask any questions that you want.
Rosalind Slaughter is a very busy wife, mother, and teacher. She didn't have time for cancer.
After my first diagnosis, I had 2 lumpectomies, but the cancer had already spread. The doctor gave me little hope for recovery. That's when I called Texas Hematology Oncology for a second opinion. It had become stage 4 breast cancer.
The physicians and staff at Texas Hematology Oncology Centers aggressively attacked her cancer and were concerned about her quality of life during her treatment. Rosalind has been cancer-free for over 8 years now.
It really makes a difference who you choose for cancer treatment.
Rosalind and others have turned to the cancer treatment offered by Texas Hematology Oncology Centers. Perhaps you should too. Texas Hematology Oncology Centers has offices that are located in Dallas, Carrollton, and McKinney. To call for an appointment, please call 469-453-5500. That's 469-453-5500.
Good afternoon, everybody. This is Dr. Dennis Birnbaum with our patient navigator, Tina Withrow, and this is Cancer Update, a short walk through a long journey. The call-in number here is 972-445-0770, and the toll-free number is 877-272-5226. Please take the time and call in if you got a question. We'd be more than happy to help you answer it. We were talking about articles, and I think it's important that people get an understanding that there are so many new things going out there on a weekly, if not daily basis that come out in the literature that they're not aware of, and I'm not too sure that their doctors are aware of.
Well, Dr. B, question that I have for you, because I read a lot. My husband even says, boy, there's a lot of cancer journals and stuff laying around this house. Everything you read is about cancer. So, and I'm not a physician and I'm not a nurse. So tell me, how do you stay up on all of this? There are a lot of information out there, and how do you distinguish between, what you can use for your patients, and how do you the volume of it is, the magnitude of it's high.
I have a mailing list that I keep up with, and I have a good office staff. They get a little bit upset that I ask them to do certain things with all these articles, but I'll go through every journal and every pamphlet or handout, and I will mark them. I put an X on every article that I want them to copy for me. Fortunately, somebody like Hilly, who knows all about computers, a lot of these articles you can pick up on the internet, so she'll go do it that way for me. And then on journals, I'll pick out the articles I want, because there are so many esoteric articles that have no meaning to my clinical application in working with the patients. So out of one journal, I may pick out 2 articles that apply to patients or apply to my treatment of the patients. A lot of the other ones are on biological mishmash or tumor markers that are experimental that have no bearing on what I'm doing. And I pick out the articles that I think would be beneficial. For example, we know about the BRCA genetic testing. Here's an article that shows if you have ovarian cancer, women with invasive ovarian cancer who carry the BRCA mutation have better 5-year survival rates than the non-carriers. And they recommend before you start any treatment that you should get a BRCA test, BRCA1 and BRCA2. And this was done over 26 observational studies throughout the United States from 1987 to 2010. That's 23 years of studies that this was done. And it showed that those people who were a BRCA1 carrier had a 5-year survival OS rate that was better than those who were BRCA negative.
I'm thinking how that relates to what I do and the patients that I know on a personal basis. I know somebody in your practice, I'm trying to think of her first name's Amy, and you did do a BRCA, and she was positive, and you did send her after her cancer treatment, and she had her ovaries removed, and that was maybe 8 or 9 years ago, and she is doing fine. So,
But now she was a breast cancer.
She was a breast cancer.
This is talking about ovarian cancer.
Okay.
This is strictly ovarian. It's the same BRCA you do for breast cancer, genetic study. They're showing that those people who are BRCA1 carrier, and you should do a BRCA1 and 2 for every female that has any female reproductive cancer, be it uterine, ovarian, or breast cancer. You should do the BRCA genetic. And if they're positive, you need to bring their family in. But this is a separate study. This is a treatment study that shows over a 20-year period of time that those women who were BRCA1 positive had a better response rate and should be treated for ovarian cancer, and their response rate was better.
I see.
All right.
Okay, I
Another
misunderstood.
article, metformin.
Oh, my gosh.
Common drug for diabetes. Used every day in the treatment of diabetes. Research has been done at the University of Texas, MD Anderson, that shows the use of metformin, one of the most commonly used anti-diabetic drug, is associated with a longer survival rate in patients with pancreatic cancer and even some forms of biliary tract cancers. The average age of the diagnosis was 64 years, 65% men, 78% non-Hispanic. Metformin use was associated with a 32% reduction in the risk of death, and the association remains statistically significant after adjusting for other clinical predictors and after excluding insulin users. So another article out there that shows that they're testing everything to see what can work, and I'm going to show you another drug in just a second that for something else.
So your metformin, if metformin regulates sugar, and we talk about how cancers love sugars, and there is a real association between high sugar spikes and low lows. So basically it goes back to keeping your body so that it doesn't have all of those peaks. So really the metformin is keeping your sugar levels.
These are articles that are coming out, research being done. Dr. Pollack brings out a editorial report on this saying these findings are receiving favorable attention. More data concerning the mechanism, pharmacokinetics, and predictor of efficiency must be studied before metformin can truly be indicated for all oncology patients. So, but they're bringing out things that are being done with other types of drugs. Let me just show you one other article that we have here talking about drugs in the use in cancer treatment, which I know now is being used. There's an antipsychotic drug has been shown to effectively control the chemotherapy-induced breakthrough in nausea and vomiting. I had read this before, and I'm using this on our patients, Zyprexa, which is an FDA-approved antipsychotic, effectively controls chemotherapy-induced nausea and vomiting in patients who fail to respond to the normal guideline-recommended anti-nausea therapy in a phase 3 trial, and this was presented at the ASCO, American Society for Clinical Oncology meeting. Just a typical drug that has been shown to be much more effective than some of the standard anti-nausea drugs used in combination. So what I'm trying to bring out is that the audience ought to bring this up to their doctor. They ought to make sure that the doctor is aware of some of the new literature that is coming out in dealing with the cancer patient treatment. Those patients who have metastatic disease to the bone. Two of the drugs that are given in that disease is Zometa or Xgeva. Recent article that came out on the use of Zometa has shown that after you give the Zometa in this disease for a certain period of time, usually it's 1 year, that you don't need to keep giving it for the second year. You can change that to give it every quarter, that the most beneficial effect of the drug has already been attained in that first year. And therefore, you can receive the same benefit by cutting back and therefore reducing the toxicity of the drug and giving it only every quarter.
Metformin, you were talking about metformin. Metformin doesn't have any side effects, does it?
Well, most of the time the metformin, you have to worry about hypoglycemia, dropping the blood sugar. You have to worry about some of its effect on the kidneys, but in general, not really. Should not cause that many, and has some GI side effects.
Okay, but definitely worth a try if this study turns out to be helpful.
Now, one of the articles we've talked about this here before, is exercise. Exercise in the cancer patient, where there's a recent article that was put out by Integrative Medicine that talks about the growing number of studies showing that exercise can be beneficial for cancer patients during and after treatment. Most studies were conducted on the breast cancer patients. They showed evidence increasingly supports encouraging cancer survivors to continue and improve physical activity levels during and after treatment. The evidence is most clear in women with breast cancer, but the few studies also showed other types of cancers. Exercise recommendations must be tailored to the individual depending on their activity levels prior to diagnosis and other limitations. Guidelines should be sought after from physical therapists or personal trainers. And these people, the physical therapists and personal trainers, must understand what type of cancer you have. And if you have metastatic disease to the bone, you should not stop exercising, but at the same time, maybe you should not be doing weight training, anything that puts pressure or undue consequences on the weight-bearing areas. And they recommend evidence regarding the impact of exercise on secondary cancer prevention and long-term mortality comes primarily from observational. Larger and better studies may reveal more specific guidelines, but they feel that the exercise program improves the overall quality of life and improves the immune system in the cancer patient.
Can people swim when they have a Mediport?
As far as I know, yes. Most surgeons I've talked to says that they should have the ability to swim and should not have any effect on it whatsoever. I don't even think that they need to keep a bandage on it. One thing I think you'll be interested in is the role of spirituality and religion coping in the quality of life of patients with advanced cancer receiving radiation therapy. Their conclusion was patients receiving radiation therapy on a religious and spirituality beliefs seem to cope better with advanced cancers. Furthermore, spirituality and religious coping are contributors to a better quality of life. These findings highlight the importance of spirituality in the care of advanced cancer treatment.
Well, a good example of that is First Christian Church in Rowlett, Texas, this Sunday is going to be, they do our cancer quilts. Anybody diagnosed with cancer gets a quilt made by the special sweet ladies headed up by cancer survivor Pam Phillips, and those quilts get blessed. What I found over the years that we've been doing this is that people really take comfort in knowing that you are praying for them. People take comfort in knowing that you are thinking of them, whatever your religious belief. And people who have a religious belief of whatever that may be, I've known that, you and I've discussed this, they seem to do better. We have one of our patients who was a recipient of these cancer quilts is in fact going to come to First Christian and just talk about what that quilt has meant to her. And I think that what you and I see on a day-to-day basis, it's really nice to know that you can go to a place and that your physician doesn't mind if you pray with him or ask that or there's something comforting, Dr. B, in saying, gosh, will you pray for me? I think that people are at a crossroads when they get cancer. They're scared. They're frightened. They have to have something that grounds them. And it does shake their belief core, because none of us think that cancer is going to happen to us. None of us think that it's going to hit our family. And certainly we're going to live forever. We never think about what's to come. And I personally, faith for me is very important. And there's nothing I love more than praying with a patient. I'll be honest. It does my heart a lot of good. And I know that it does a patient, and there's something about holding hands with somebody and praying them through it. It just makes all the difference in the world. So they didn't need to spend $500,000 on that study. They could have given me $200,000, and I would have told them.
That's a good point. I know in my training, None of this is ever brought out. A lot of doctors I know and oncology just think that this is hocus pocus. But I will tell you, over time, for me as an oncologist, I think religion and spirituality have an important part in the quality of life of the patient. To sit there and pray, or to hear patients say that they pray that you, Dr. Berenbaum, make the right decision.
I hear that a lot.
That you are guided in the right way, that you are here for a purpose, and I came to you, especially if they're responding. It's really something to me as an individual to see that a patient has that much feeling about their doctor and trust in their doctor, that they're praying for their doctor to make the right decision. But overall, and I'm not a religious person that I attend synagogue every weekend, my point is that I have found mostly in the ability to live, the ability to go on, and the quality of life is markedly improved in those patients that either believe in religion or who now take up religion, which they hadn't been involved in before, or they have gone to a support group like one of your support groups and they have prayer, either prayer to help save everybody or prayer to make sure that they go through their therapy okay. It is very rewarding to see a lot of the patients, if they're in one of our infusion chairs, they're reading something or they're reading a book that has spirituality. Even some patients are reading the Bible. That is a very eye-opening moment for me as an oncologist and seeing this in patients, because I will tell you that probably over 50% of my patients reveal this innermost abstract feeling about themselves to me or to you or to other people of how important religion or spirituality is to them.
We have a patient that had a mass in her belly, I think it was, and she had some scans done, and when she came back, for whatever reason, it left. And she believes that's through prayer. So, you and I both know we don't know why certain things happen.
Everybody, we're getting near the end of our program. It is supposed to be very hot, 105 to 106 degrees this weekend. Please wear sunscreen if you're going to be foolish enough to be outside. Have a nice weekend. Be careful, and join us next Friday for Cancer Update, a short walk through a long journey.
Bye now, everybody. Good luck, Malia.
Listening to Ask the Pros, heard every Monday to Friday right here on 770 KAAM. Should you wish to speak with any of our experts, please call KAAM at 972-445-1700 and we will connect you with them immediately. Thank you for listening to Ask the Pros.
The views expressed in the preceding program were those of the speakers and not necessarily those of KAAM, DJRD Broadcasting, or its sponsors.